All right, I hope I am audible to all. Yes. So this video is about targeted Tuesday session psychiatry. So we are going to discuss a short MCQ. I hope the people in the live chat can see me, can hear me. So shall we begin? Yes. Okay. So this is a short psychiatry session. So today I have selected an MCQ on the topic of alcohol withdrawal. Alcohol withdrawal has been an important topic for NEETPG. It has been asked in INICT as well. As far as the NEETPG is concerned, in the last 5 years, they have asked 2 questions on alcohol withdrawal. First question is this. A patient stopped alcohol for 3 days, so they have already mentioned, presented with irritability, disorientation, paranoid delusion, visual hallucination, and altered sensorium. Likely diagnosis. Now, this is a case of alcohol withdrawal delirium. Delirium because it is present for approximately 72 hours. 72 hours. There is no history of generalized tonic-clonic movements. So there's not a seizure. It is not a Wernicke encephalopathy that presents with global confusion, ophthalmoplegia, and ataxia. It is not a Korsakoff psychosis that presents with recent memory loss and confabulation. This alcohol withdrawal is known as delirium tremens that has been asked in the exam previously also. Delirium tremens, the hallmark feature is here altered sensorium, or you can say disorientation to time, place, person. Disorientation to time, place, person. It also presents with psychotic symptoms like delusions and visual hallucination. Okay. How to differentiate delirium tremens from alcoholic hallucinosis? A person in the live chat, Kamaran, has asked this question. Alcoholic hallucinosis always presents with auditory hallucinations in clear sensorium. There will not be any disorientation, while delirium tremens always presents with visual hallucinations in altered sensorium. Do you understand this? Do you understand this, Kamaran? Another question was asked on the same topic, although I was supposed to take only one MCQ today, but when I was searching for last 5 years NEET questions, I found that this question has been also asked in NEET 2018. Chronic alcoholic presented to the emergency with irrelevant talks. Why would somebody talk irrelevant? Irrelevant talk means psychosis or disorientation. He's talking to hallucination. He's talking to himself. He's not understanding what you're trying to say. Tremors, sweating, last drink 3 days back. What is the answer now? Again, delirium tremens. That's why it is important to do previous year questions before attempting the exam. 2018 paper it was asked, 2021 paper it was again repeated. So it has been asked twice, 2018 paper and 21. Please remember, Korsakoff psychosis you will only mark when there is frank amnesia. Discontinuation syndrome is also known as withdrawal. Now please understand, alcohol withdrawal is a very important topic. The features of alcohol withdrawal are this. This is the sequence in which the alcohol withdrawal goes. Tremors, it is the first symptom, key symptom, most common symptom of alcohol withdrawal, because when the person is withdrawing from alcohol, the norepinephrine increases because alcohol acts on GABA that balances the inhibitory part in the brain with respect to the three stimulatory hormones norepinephrine, dopamine, and glutamate. So, alcohol potentiates GABA action and makes the brain inhibited. In the absence of alcohol, the inhibition is less and the stimulatory part is more. So, alcohol makes the brain inhibited, and in the absence, the brain is excited. So, norepinephrine increases in the first 6 to 8 hours of withdrawal. That's why this withdrawal is called mild withdrawal. Mild withdrawal happen if the time since last drink is 6 to 8 hours. This question has been asked many times. Most common symptom, key symptom, and first symptom. Please remember, hangover is not the first symptom of alcohol withdrawal. Richa Pandey, you have asked me in chat, why not Korsakoff? Korsakoff will present with amnestic syndrome plus confabulation. It is seen in chronic alcoholic that presents with frank amnesia, recent memory loss, plus confabulation, that is filling up the gaps in the recent memory. Don't mix Wernicke's, Korsakoff, and delirium. Delirium is a frank alcohol withdrawal state. Then comes autonomic hyperactivity, tachycardia, and increased BP. Up to this, the withdrawal is mild. Then the withdrawal becomes moderate. Moderate withdrawal is seen in 8 to 12 hours of the last drink. It is due to increase of dopamine. When dopamine increases, the person has paranoia and hallucinosis. Paranoia means fixed delusion. Unlike delirium tremens, where we have fleeting delusions, alcoholic paranoia has fixed delusions. Always present delusions. Always present, not fleeting. Alcoholic paranoia again happens in clear sensorium. Somebody was asking, Kamaran, you're asking me the difference between alcoholic hallucinosis and alcohol withdrawal delirium tremens. Hallucinosis is auditory hallucination in clear sensorium, while delirium tremens is visual hallucinations in altered sensorium. I hope it is clear. This is how the withdrawal is progressing. This is how the alcohol withdrawal is progressing. Now, this is your moderate withdrawal. Then seizure comes under severe withdrawal, that is 12 to 24 hours of the last drink. Then delirium comes in life-threatening withdrawal, that comes in 24 to 72 hours of the last drink. Delirium does not set within 24 hours. It takes at least 24 hours to set in. So as the time since last drink is increasing, the withdrawal is getting more severe. More severe. Delirium tremens has visual hallucination, altered sensorium, disorientation, autonomic hyperactivity. How to differentiate between fixed delusion and fleeting delusion? Shreya Singh. Reshma is asking example of these delusion to know the difference. Of course, I'll tell you. Good that you are interacting. Fleeting means not always present. At one moment, the patient will say somebody is coming to kill me, and another moment he will say nobody is coming to kill me. This is characteristic of delirium. Unlike schizophrenia, where there are fixed delusions, schizophrenia will have delusion of persecution in the morning, delusion of persecution in the evening, delusion of persecution on 16 December, on 17 December, on 18 December. Delirium will suddenly say somebody is going to kill me. At another moment he will say nobody is going to kill me. So fleeting and fixed is just time dependent, not theme dependent. Reshma, you were asking example of these delusion. Fixed delusion are mostly paranoid delusion. People coming to kill me. in clear sensorium. In altered sensorium, it is fleeting. I hope it is clear. Now they also ask you treatment of alcohol withdrawal. Treatment. Now the treatment depends on whether it is mild, moderate, severe or life-threatening. Ultimate treatment is benzodiazepine plus thiamine. Benzodiazepine is the drug of choice for alcohol withdrawal, and thiamine we give to prevent Wernicke's encephalopathy. As long as it is mild and moderate alcohol withdrawal, we give oral benzodiazepine plus thiamine. And the oral benzodiazepine of choice in mild and moderate withdrawal is chlordiazepoxide. Chlordiazepoxide, because this has longest T half. But in case of seizure, we can't give oral medication since the patient is having a seizure, so we give IV diazepam plus thiamine, and in delirium we give IV lorazepam plus thiamine. In seizure we give IV diazepam plus thiamine, and in delirium we give IV lorazepam plus thiamine. These questions, if you have attempted a recent INI-CT exam, have been already asked. In INI-CT November 2022, this was asked. In INI-CT May 2022, this was asked. So these are very, very important questions. I hope you people understand why I have taken the topic of alcohol withdrawal as short question. Now, we give this treatment for a period of 7 to 10 days only. This treatment is called detoxification. Detoxification is treatment of withdrawal. Because the patient is having withdrawal symptom, we give benzodiazepine. But benzodiazepine itself being a drug of dependence, we cannot give benzodiazepine for long period. So once the detox period is over, we start de-addiction proper. Please understand, de-addiction proper is a different thing. It is to prevent relapse. Now the patient has already quit alcohol. Now you have to prevent relapse. So for that, we have two types of agents. Either we have anti-craving agent or we have deterrent agent. Deterrent agent is known as aversive therapy. This repels alcohol. Can anybody tell me the name of deterrent agent? If this is in the blood, alcohol can't enter. If this is in the blood, alcohol can't enter. It repels alcohol, but it is not an anti-craving agent. It's a very famous drug. People used to mix it in the food of alcoholics so that when they take alcohol, there's a reaction and the patient vomits. Absolutely correct. The answer is Disulfiram. For Disulfiram to be given, patient must be off alcohol for 12 hours at least. Now last INI-CT, they also asked the mechanism of action of Disulfiram. It is aldehyde dehydrogenase inhibitor. Alcohol gets converted to aldehyde get further metabolized, so disulfiram is aldehyde dehydrogenase inhibitor, so it accumulates aldehyde which causes disulfiram ethanol reaction. So when the person takes alcohol and he gets accumulation of acetaldehyde which causes disulfiram ethanol reaction. When do I use deterrent agent? When the patient has very poor motivation. But nowadays mostly we are using anti-craving agents in the form of acamprosate. It is NMDA antagonist and naltrexone. It is also an opioid antagonist. So these are the three drugs used as anti-craving agents. Two drugs, acamprosate and naltrexone. There are some more drugs used as an anti-craving which are not yet approved. But used as anti-craving. Anybody knows the name of those drugs? Which are not yet approved but used. Very good. Ondansetron, fluoxetine, very good. Baclofen, excellent. Topiramate, very beautiful. Very good. All these are anti-craving for alcohol which are used but not yet approved. So that's why a question comes, if a patient takes alcohol and opium together, what is the de-addiction drug of choice? If a patient takes alcohol and opium together, what is the de-addiction drug of choice? Come on, what's your answer? Naltrexone. And if I change the question, if a patient takes alcohol and nicotine or tobacco together, what is the de-addiction drug of choice? Can you name a drug which acts as alcohol anti-craving as well as nicotine anti-craving? Can you name a drug which acts as alcohol anti-craving as well as nicotine anti-craving? No, Reshma, it's not acamprosate. Yes, Sagar, it is topiramate. So let us summarize. Only alcohol. It is A for alcohol, A for acamprosate. Alcohol plus opium, naltrexone. Alcohol plus tobacco, topiramate. This chart, do you think it is helpful? Do you think it is helpful? Obviously, only opium, naltrexone. Only tobacco, it is varenicline, which is better than bupropion. Are you noting it down? Are you noting it down? It's a very, very important chart. I've never given such chart in the class as well. You know, sure short MCQ means something from this is supposed to come. Do you understand this? You will not realize, but in the last 15 to 17 minutes, I have discussed more than 20 MCQs. Now the last point. Alcohol dependent people also have alcoholic liver disease because they are using alcohol for a long time. So definitely they have alcoholic liver disease in the form of hepatitis, cirrhosis, portal hypertension. So if you get an alcoholic with deranged LFT, liver function test, that is evidence of alcoholic liver disease, would you give a benzodiazepine that puts less pressure on liver, or would you give a benzodiazepine that puts more pressure on liver? because benzodiazepine also are metabolized from liver, but there are some benzodiazepine that undergo hepatic glucuronidation and hepatic oxidation. That means they put more metabolic pressure on liver. And there are some benzodiazepine that only undergo hepatic glucuronidation. Which one would you prefer? Left one or the right one? This one. So there are benzodiazepine who love liver. What is the answer? Lorazepam, asked in NICT November 2022. Oxazepam, asked in NICT May 2022. Two questions, two consecutive NICT. Do you understand this? And the benzodiazepine that put more pressure on liver, chlordiazepoxide and diazepam. Do you understand this? A very important MCQ. Do you understand this? These two benzodiazepine put more pressure on liver. This benzodiazepine puts less pressure on liver. So these benzodiazepine love liver. Love. L-O-V-E, liver. L-O, love liver. Lorazepam and oxazepam, chlordiazepoxide and diazepam. So in short, in the last 20 minutes, I have discussed with you two MCQs, along with that a topic of alcohol withdrawal. Before I close this video, I would again show it to you what I discussed in the next 30 seconds. I discussed this question asked in NEET 2021. The answer was delirium tremens because the patient has delusion, hallucination, altered sensorium, disorientation for last 72 hours. There's no GTCS, so there's not seizure. There's no ophthalmoplegia ataxia, so it's not Wernicke case. There's no recent memory loss plus confabulation, so it is not Korsakoff. Somebody asked me the difference between alcoholic hallucinosis and alcohol withdrawal delirium. Hallucinosis occur in clear sensorium and withdrawal delirium occurs in altered sensorium. A similar question was also asked in NEET 2018, where again the answer was delirium tremens, but there was no disorientation, rather irrelevant talks was given. It is not Korsakoff because it is not amnestic syndrome. So these are the 6 signs of alcohol withdrawal in increasing severity. We have discussed when it happens, why it happens, what is the neurotransmitter involved, and we have also discussed treatment. Alright, so I hope this short session of MCQs was helpful for you today. I would like to have your reviews, opinions, suggestion, comments about today's session. The people who haven't watched it live, they are more than welcome to watch it recorded. I'm sure that this 20 minutes revision is not going to be wasted. I suggest, request, advise everyone on 5th of March when you give NEETPG and any question comes from today's session, do let me know. I would be more happier than you as well to understand that yes, something from what I have taught has come from a YouTube session. Okay, I usually don't teach much on YouTube, but when I'm given a chance, I try to. So this chart is a very important short MCQ. Alcohol plus opium, alcohol plus nicotine, only alcohol, only tobacco. Take a snapshot, take a screenshot. Alcohol with alcoholic liver disease, derange LFT. We will give benzodiazepine, that more important. Okay, thank you very much. Have a nice day. Bye bye.